going to introduce the next speaker, who is Dr. Michael Friedlander. He's a professor of medicine at the University of New South Wales and director of medical oncology at the Prince of Wales Cancer Centre in Sydney. He's an internationally recognized key opinion leader on gynecological and breast cancers, and he is actually instrumental in setting up the first hereditary cancer in Australia. So he is involved in a number of key PARP inhibitor trials and has published extensively. So today he's going to tell us about beyond BRCA testing. Does HRD matter?
Thank you very much. It's a great honor to be here, and I will discuss beyond BRCA, and obviously you've had a fantastic introduction. I'm not too sure I can add much more to what's been said, but I will perhaps embellish or expand on some of the points that have been raised. So the topic I was asked to address was beyond BRCA testing, does HRD matter? And the answer is yes, it does matter. And what I'm going to talk about today is a number of topics, and I'm going to talk about how do we identify beyond BRCA testing patients who are likely to benefit from a PARP inhibitor. I'm going to touch on briefly the elusive definition of platinum sensitivity and platinum resistance, because this impacts significantly on our practice, and those definitions actually make a difference. And I think if we use them sensibly, we can identify potentially identify patients with HRD, because platinum sensitivity, in fact, is probably a very good marker of HRD. I spent a bit of time talking about the methodology and the methods that are currently available to assess HRD, and then I'm going to discuss some of the trials. Many of them you've actually heard of already, but I'll spend a bit of time on them, and we'll talk about not specifically BRCA, but how HRD impacts on response. And it's not simply looking at hazard ratios, but looking at some of the nuances in those clinical trials. And then I'll touch on a few other things. So predicting PARP sensitivity. Well, BRCA mutations, germline and somatic trump everything. So that they really are the most important, but followed not too far behind are by HRD mutations, and then a number of clinical factors, which all kind of are interrelated, because platinum sensitivity, the number of lines of prior therapy, and histology, and I'm focusing mainly on ovarian cancer, but I'll touch on some of the others in a moment. So those are all important factors. So why is HRD important? Well, the previous speaker has gone into that in great detail, but it's the fundamental basis behind the mechanism of how PARP inhibitors function, as well as indeed how platinum actually works. And BRCA mutations are the prime example of HRD, exquisite sensitivity to PARP inhibition, as well as to platinum-based chemotherapy and anthracyclines, as in fact in any alkylating agents. But we know that PARP inhibitors have activity in BRCA wild type, and there are many other mechanisms for HR deficiency. And we're going to talk a bit about that in ovarian, breast, and pancreas. But most mature data is on ovarian cancer. Now, you saw this slide, and I won't belabor it, apart from just stressing that about 50% of high-grade serous cancers harbor deficiency in homologous recombination. And that's in contrast to about 40% of triple-negative breast cancers, and in fact about 13% of triple-negative breast cancers also have a BRCA mutation. So there's a high proportion of patients with high-grade serous cancers who have these deficiencies. And one of the problems is in the clinical trials that have been designed so far, we have not used these criteria to stratify. For example, in all the frontline trials, we've used so-called response to platinum. But that's in many respects a misnomer, because in patients with advanced stage ovarian cancer who've had upfront surgery and either have no macroscopic disease or very small volume disease, it's very, very difficult to measure response. So to assume that because a patient has no evidence of disease at the completion of treatment, to assume that that actually equates with platinum sensitivity is naive. And that probably explains why not all patients respond as well as you would expect who've so-called incomplete response to platinum-based therapy. Because if we could select out the subgroup who have homologous recombination deficiency, I think we'll see even better results. But at the moment, we really can't do that. Now, the other question, of course, that I think has been briefly touched on is, are all these mutations in the homologous recombination repair genes created equal? Do they all predict for response? And the answer is no, they are not all created equal. There's some that are tend to be associated with a much higher response rate than others. Now, these are a couple of studies that just represent the frequency of somatic gene changes that are seen in ovarian cancers, and they range from about 8 to 20%. The majority being BRCA1 and BRCA2, but a smattering of RAD51, PALB2, ATM, etc. And this is a really neat study from GOG 218, where they managed to go back and look at about just over 1,000, almost 1,200 patients who were enrolled in this trial, which is looking at the addition of bevacizumab to carboplatin and cisplatin, carboplatin and paclitaxel. I won't go through the trial design because that's not that important, but I think what is important is that they managed to find that 25% of these patients had mutations in the HR pathway. Majority, as you would expect, were BRCA1 and BRCA2, with about 6% in other homologous recombination pathway genes. And you can see that the BRCA2 patients were the ones that did particularly well, but there wasn't much difference between BRCA1 and the other HR genes. So there are multiple potential mechanisms for HRD beyond BRCA1 and BRCA2. There are mutations in many other HR genes. There's genomic scars. There's promoter methylation in BRCA1, for example. There are other mechanisms. But the net effect is impaired DNA repair and genomic instability, which equates with PARP sensitivity and platinum sensitivity. So they all tend to hone in on the same pathway. So the challenge before us, and clinically, is to identify patients with BRCA1 and 2 wild-type tumours with alterations in this pathway who will benefit from PARP inhibitors and possibly from platinum-based chemotherapy as well. And there are a number of ways we can potentially do this. We can do this by looking at germline mutations. We can look at somatic mutations of the HR genes that I just showed you a few moments ago. Functional assays, I think, probably are going to be the key, but at the moment really are not really that practical. But I think in time we'll probably see functional assays. And then there's obviously genomic scars and mutational signatures. Now, when you look at the various definitions and the panels that are used for HRR genes, you see there's significant variability. In fact, there's no university-defined gene list. They're all different, and therefore that all going to impact on what you find in particular patients. And I don't think we're there yet in terms of identifying what the ideal or optimal panel is, although apart from recognizing that they are important. But which ones are important, which ones should we be testing for, I think that's still a work in progress. We've learned quite a lot, I think, from going back and looking at some earlier studies. And study 19 was really it's a really important trial because it sort of set the ball in motion. Everything happened after study 19 because this was the first study that was demonstrated a potential advantage or benefit of olaparib in patients with platinum-sensitive recurrent ovarian cancer in terms of the progression-free survival, and that was independent of BRCA. And about 22% of patients had BRCA wild type, and they had a number of mutations in candidate repair genes. But what is important as well, that if you look at the hazard ratio, and the numbers of patients are quite small, but these were patients who had BRCA wild type, but mutations in the HRR pathway, and you can see that the hazard ratio for PFS was 0.21, which is not that different from the BRCA mutant subpopulation. So the challenge really is identifying who those people are and using panels that will pick them up. And as the previous speaker just told us, and I won't belabor this, that there's HRR mutations in not only ovarian cancer, but in breast cancer and pancreatic and prostate cancer, but that's just been mentioned earlier, so I'm going to move on. So the test that has been used predominantly in the frontline trials, that's in PRIMA and PALO and VELIA, were Myriad My Choice. So that seems to be the most popular test at the moment, and this uses 3 factors to determine a score: loss of heterozygosity, telomeric imbalance, and large-scale transitions. And the score is defined as greater than 42 or BRCA mutation, and about 50% of high-grade serous cancers are HRD positive based on the Myriad My Choice assay. Now, one of the real big problems with this assay and this test is that it's hardwired. It doesn't change. So if you've got a reversion mutation, or you're resistant to a PARP inhibitor, you're resistant to platinum, you're still going to be HRD positive. So this is the really big problem using this test. And that's why we see such variability depending on the populations of patients treated. So if you look at, and we'll come to that in a little while, if you look at patients who've been heavily pretreated and had multiple lines, they're still HRD positive, and they may have a modest benefit from a PARP inhibitor or for platinum, despite the fact that they seem to have a high score. So we can't simply rely on the score. I think other clinical factors have to be taken into consideration in terms of how many lines of treatment has that patient had, have they progressed on platinum. All these factors are important beyond simply looking at a number in the score. And as the previous speaker also alluded to, where does that 42 come from? 42 was a figure that Myriad selected as was a threshold for the 95th percentile of HRD scores observed in tumours with BRCA1 and 2 deficiency. It was not based on any clinical outcome or any response data. And if you go back and look at the study 19, which was an exploratory analysis, and if you used an HRD score of greater than 33, and there was 185 patients, you can see the hazard ratio was 0.25. So arguably, it would be more sensible to use a lower cutoff, such as 33, and it'd be very interesting to see if the companies that have done and sponsored the trials that we've all heard about, if they went back and looked at that, could we actually then separate a population of patients who definitely are not going to benefit from a PARP inhibitor, and that if that happens, that remains to be tested. Having said that, if you look at the studies, VELIA did use a cutoff of 33. The others used 42. We've seen this as well, and I won't belabor it, but the other assay is the Foundation Medicine T5 assay, which calculates the percentage of genomic loss of heterozygosity. And initially they used a pre-specified cutoff of about 14% to define loss of heterozygosity, and reanalysis suggested a 16% cutoff was a better discrimination, and in fact 16% was the cutoff that was used in Ariel 3, and I'm going to talk a bit more about Ariel 3 in a few moments. But essentially those are the 2 tests that have been used in all the trials to date, and I think Myriad at the moment probably has the runs on the board and is used more commonly. Now what if we then drill down and focus on HRD? I'm not talking about BRCA now, but it's HRD and benefit from PARP inhibitors. And if you look really right across the board, whether it's Ariel 2, Ariel 3, NOVA, or the first-line studies, or even the fourth-line studies such as Quadra, you see consistently that the HRD population do appear to benefit more than the HR proficient. And we'll go through that in more detail, each study one by one. This is a recent analysis that was actually well worth reading. It was published very, very recently. And it looks at many things. I've just showed you here the HRD in the wild-type population. You can see clearly in the various studies in the platinum-sensitive space, HRD makes a difference. And I think it makes a difference depending on how platinum-sensitive the patients are. Because platinum sensitivity per se is a really good marker of HRD. And if a patient has ovarian cancer and she relapses 2 years or 3 years or 4 years later, you can be 100% certain, or pretty close to it, that she's got a tumor that has an HR deficiency, irrespective of what your score actually shows. And one of the things that none of these studies have actually drilled down on, I think to any great extent, is looking at the platinum-free interval. And that comes in a few moments to how we define platinum sensitivity. But if you look at the platinum-free interval, and I'm talking about now by RECIST, not by CA125, I think you can actually identify a subgroup of patients who will respond very well. And this is probably one of the reasons why HRD populations seem to do a lot better in the platinum-sensitive group compared to the upfront, because these are truly platinum-sensitive. So I have a thing about these definitions. The definition of platinum sensitivity and resistance came about many years ago, and it's stuck, and people really haven't questioned it very much, but they're used widely. So when platinum sensitivity and resistance was first defined, it was based on progression, actually not even resist progression, it was based on clinical progression. So these are women who had had chemotherapy for ovarian cancer and then progressed, often clinically or radiologically. Remember, in the early 80s, CT scanning was at its infancy. And there's a world of difference between someone who's completed chemotherapy for ovarian cancer, who has a rising CA125 4 months after stopping chemotherapy, versus someone who's got a 10-centimeter mass in her pelvis. And they both call platinum resistance. And so how you define sensitivity and how you define resistance makes a big difference. And now these terms are used for first line, second line, third line, and beyond. And there are real problems with these definitions, and I think they really have muddied the waters. And so when you look at trials of so-called platinum-sensitive ovarian cancer, it's really important to try and understand who are the population. Are these women entered in the study because they had a CA125 that went up 6 months after treatment, after completing treatment, or do they have resist progression 2 years or 3 years later? Those are different populations, and they're going to respond differently to second line or subsequent treatment, and I'd argue also to PARP inhibitors. And using platinum sensitivity in conjunction with your HRD score is, I think, critical, at least in the clinical setting, if not in clinical trials. Now, moving to some of the trials in a bit more detail. These are the platinum-sensitive population, and this is Ariel 3, rucaparib. And you can see in this particular study, I'm going to focus on the BRCA wild type with high LOH, and 28% were LOH high in the BRCA wild type, and they used the cutoff of 16%. And you can see that in the LOH high versus LOH low, there clearly is a big difference in favor of LOH high, but this really wasn't good enough at discriminating between a group who's not going to benefit, and even in the LOH low, we did see some clinical benefit. So it's good to discriminate in clinical trials, but whether in fact we can use this and how valuable it is in the clinical setting, I think is questionable. And I think you've got to once again take into account the clinical factors, the degree of sensitivity, the site of disease, and multiple other factors, because I just think using a cutoff of 16% really isn't enough. Now, in the NOVA trial, which is a maintenance trial, I'm going to focus now on the non-gene BRCA population. And if you look at these, the germline clearly do very, very well, and the non-germline BRCA with HRD positive also have a significant benefit. But it's important to also recognize in the NOVA trials in particular, they included somatic BRCA in the HRD positive, which obviously in some ways improves or increases the likelihood of progression-free survival. And if you look at no germline BRCA mutation, once again in favour of niraparib. But this is important to understand that the HRD population definitely do seem to benefit, and it is contaminated to some extent with the somatics. The quadrome, I guess, gets to the point about even if you are HRD and you've had multiple lines of treatment, and these patients have had at least 4 or more lines of treatment for recurrent ovarian cancer, there was a lot of patients who were HRD positive, 189 in the study, and you can see that if they were platinum sensitive, the response rate was about 26%, and if you're platinum resistant, it was a lot lower. So even though they're HRD positive, platinum sensitivity makes a difference. But even in this particular setting, because they had so many lines of treatment, even though they're HRD positive, it doesn't necessarily mean that they're going to respond to treatment. So common sense should always prevail, and understanding how many lines of treatment, and particularly if patients have progressed while on treatment, because that usually is a pretty good clue that they're not going to respond very well to subsequent treatment. So platinum sensitivity always counts. The maintenance trials, which we've all heard about, the PRIMA, the PAOLA, and the VELIA, they all showed clear and unequivocal benefits in the BRCA population. No question about it. They all used myriad my choice, but PRIMA and PAOLA used a cutoff of 42, and the VELIA used a cutoff of 33. And I'm not going to go through the design of the trials because you know them well, but I'm going to talk about the HRD. But if you look at them, they're pretty similar. About 30% or so of patients had BRCA mutations, and about 50% in total are HRD. Interestingly, and we haven't talked about this, in about 15% to 20% that's HRD unknown. It's for technical reasons. It just fails. It doesn't work. And we can't forget about that. There are many reasons why it doesn't work. Sometimes it's technical. Sometimes the blocks are old and they hasn't been fixed properly. So you're often going to get, or maybe up to 20% of the time, the results are going to fail. Now, these trials all showed there was a clear and unequivocal benefit in the BRCA population and in the HRD positive population. Remembering, of course, the HRD positive included BRCA. When you remove BRCA and just have HRD positive BRCA wild type, there's slightly less. The hazard ratio is less, drops to about 0.5. HRD negative in PRIMA was 0.68. I'm going to come to that in a few moments because I think there's a problem there. And interestingly enough, when you look at the HRD negative or unknown in PAOLA, no benefit at all. And whereas in the others, there was a benefit. And in VELIA, the main benefit in VELIA, once again, it's the populations of patients are different. In VELIA, it was really only the BRCA population who benefited from treatment. So this is HRD negative. In VELIA, even though the hazard ratio looked like, just 0.8, there's really no meaningful difference between those two curves. And in PAOLA, no difference either. So I think we can select out a group of patients, at least in the maintenance setting, first line, who are HRD negative or are not going to benefit. Now just look at the PRIMA data. There's no patient numbers, there's no censoring, and the curves are exactly the same. They parallel each other. I just don't get it. How did that happen? Now, that wasn't in the New England Journal of Medicine, but that's what has been reported. So I still think, even though that showed a difference, I'm not convinced. So I personally think that if you have an HR proficient tumor based on myriad, in the first-line setting, I personally wouldn't be trying to convince a patient to have a PARP inhibitor. I think there are better things you can probably do, such as bevacizumab or whatever else, but I just honestly don't think the data there support a PARP inhibitor. So there's some limitations of these maintenance studies. First of all, response to platinum is impossible to assess in many patients who have had optimal or even suboptimal residual disease. We just don't know. There are limitations of resistant ovarian cancer, and CR at the end of 6 cycles is a misnomer. We cannot be confident that it reflects platinum sensitivity in all patients. And platinum responsiveness is a continuum. One way that I think we might possibly be able to predict which patients truly have HRD in the first-line setting is looking at the chemotherapy response score. So more and more patients are having upfront chemotherapy, neoadjuvant chemotherapy, in some cases up to 50%. I think that's far too much, but that's what's happening. But the chemotherapy response score, which is what the response in the omentum is, if you have a CRS score of 3, and that means that you've really got essentially a complete pathological response, that's up to about 30% of patients have that. Those patients do very well. If you have a CRS score of 1, and that's where the tumour looks very, very healthy, there's tons of cancer there, it essentially hasn't worked, those patients do really badly. And then you've got the CRS2, which is somewhere in between. So you could potentially use those and incorporate that into your clinical practice if you're doing neoadjuvant chemotherapy, and if you have a CRS3, then that patient probably has an HR deficiency, and you may not even need to go beyond that and just use that as a pragmatic approach. If they have a CRS1, I wouldn't be rushing in to give them a PARP inhibitor unless I knew that they actually had a HR deficiency, and even then it may not probably work. Now, unfortunately, no one's actually been able to relate response in the neoadjuvant setting to benefit from PARP inhibitors. But one thing, if you go back and look at the SOLO-1 data and look at neoadjuvant, and there are many reasons why people have neoadjuvant chemotherapy, sometimes because they're not well enough to have upfront surgery, but sometimes because of convenience or because it's just an easier thing to do. But if you look at the outcome in patients who got neoadjuvant chemotherapy, it is much worse than upfront surgery. Now, part of that might be selection, but part of it may possibly also be due to BRCA reversions. I don't know if it's such a good idea to be giving people who've got large, bulky tumours a lot of platinum up front, because there's high mutation rate. I think there's potentially the possibility of developing BRCA reversions, and in fact there are some data to support this. So that's just a mind bubble or thought bubble, but I just threw that out there. We've heard about prostate cancer, so I'm not going to spend any more time on that because we've just heard about that. So just in conclusion, beyond BRCA, HRD to predict PARP benefit. So I think first of all, there's a limitation of using genomic scars. It's a myriad assay, hardwired, static, even if there's restoration of HR function. The HRD assays, they have a way to go. But they do, at this point in time, they do identify a subset of patients likely to benefit, and the patients, particularly in the frontline setting that are HR proficient, I think do not benefit from treatment. I think it's a little bit less clear in the recurrent setting because platinum sensitivity may trump all these things. Functional biomarkers are probably going to be where we're going to be going, but at the moment there's lots of technical issues with them. And I think we can use extreme platinum sensitivity, multiple responses to platinum as an indicator of HRD-ness in the recurrent population, in particular select patients. And in the first-line setting, it's the BRCA mutants and the HRD subset that benefit the most. And thank you very much.